Tube MR Happy writes, Cyrus has some, all caps, insane guns.
Oh,
3
wow.
exclamation points.
That's really embarrassing. That must come from the episode that we recorded together. And I think I made a point of wearing a shirt with sleeves that were like several sizes too small just to really accentuate my arms.
Were you even wearing a shirt? Yeah.
I don't know. Like things got pretty hot and heavy in there. I don't even remember.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Nick Mark.
And I'm your other host, Dr. Cyrus Aston.
All right, well, this week we're going to do something a little bit different. We typically end our show by saying a big thanks to our listeners and asking y'all to write to us with your questions. Well, today, instead of ending with that, we're going to lead with that.
Yes, this is our opportunity to say thanks to our listeners, highlight some of their comments. We're super excited, like Nick was kind of alluding to share the feedback. And so here's an episode where we get to read your comments and reply and really just thank you guys for listening to us a couple times a month.
Yeah, and spoiler alert, you guys are pretty smart. You guys are a bunch of smarties. You know, we not only do we appreciate your feedback, you know, you have nice things to say, but you ask really smart questions and you make really smart points that have sent us running to like PubMed, ChatGPT, Reddit, etc. So thank you for making us smarter too.
Yes, my inferiority complex really appreciates it.
There's some praise you'll appreciate when we get a little later in this episode, man.
Okay, well, we'll see. We'll see about that.
Your ego will grow a little by the end.
Okay. Excellent. Yeah, my wife will appreciate it.
All right, here we go.
All right, so we'll kick things off by talking about difficult airways. For you guys that have been listening to us recently, you may know that we've recently partnered with the Difficult Airway course, and we look forward to bringing some more collaborative content to you guys in the coming season. But before we get to that, we're going to share some feedback from David and Grace Dawson with respect to the anatomically difficult airway episode. I guess it's a single person, I think, but they're using the @David and Grace Dawson 2920. And they write, "Hey, I'm a CCRN and enjoy y'all's podcasts a lot. Something interesting to listen to on my long commute. But I wanted to ask you about paralytics after an awake intubation. I'd always thought the whole purpose of paralytics during intubation was to be able to pass the tube easily through the cords without spasm and without patient movement in general. So if you've already accomplished that by topicalizing and using moderate sedation and the tube is secured, it seems like there's just no need. You're not going to keep the patient paralyzed the whole time they're intubated, right? So why give the dose at all? Light sedation should be enough to prevent complications from cough/gag reflex."
Okay, really smart point, David and or Grace. I completely agree with you that if you have perfectly topicalized the cords and you've just absolutely dialed in that level of moderate sedation, the paralytics and deeper sedation may be unnecessary. That said, what if you didn't perfectly topicalize the cords? What if, you know, you thought you did, but as soon as the tube is through the cords, they start coughing and they cough out the tube? Or what if they're not sedated quite enough and that stimulation causes them to wake up and yank the tube out of their mouth or nose? Remember, you're doing an awake intubation for a reason. And if you lose your tube, you know, it's going to be really, really bad. I always like to remind people of the famous Napoleon quote, "The time of greatest danger is right after victory," right? Nothing worse than you get the tube in and then something happens right then. So the way I view it is that paralytics and deeper sedation are kind of a safety margin that we can use, giving us enough time to secure our tube, confirm positioning, etc. Even though I agree with the premise of your question.
Yeah, I think I agree too. This is kind of the time in a patient's course that can be the diciest, the most perilous time that they're going to spend with you. And so I think anything you can do to gain an upper hand and thereby give your patient an upper hand is really going to be beneficial. That being said, I think the spirit of this question is very well taken. You know, we know that there are risks associated with neuromuscular blockade, and we certainly would not advocate for utilization of NMBs without a very purposeful, approach. For example, we talked about in our ARDS episode, potentially using it in extreme cases of ventilator dysynchrony or in patients that you're proning potentially. But remember, we're being very hedgy about this because I think we need to be. There are, the risks of myopathy, long-term weakness, so on and so forth are not to be taken lightly.
Good points. Okay. Moving on to the cardiogenic shock episode. Max A writes, "Hey guys, great episode as always. Quick cue about AT2. I've never thought of this as a med for CV shock. I didn't realize it had chronotropic/inotropic effects. That said, I've been taught to not use in CV shock and that the Athos trial only included patients with CI greater than 2.3 or SVO2 greater than 70. Do you use this for CV shock in your practice? Happy to expand my arsenal for CV shock if possible. Just wanted to check since info in this episode is a bit different than what I've heard in the past. Thanks."
Okay, yeah, so absolutely right. So Athos enrolled patients with features of high output shock. So that would be like a SCVO2 greater than 70%, CVP greater than 8, or a cardiac index above 2.3. So not your cardiogenic shock patient. But there has actually been a little bit of literature since then that may open the aperture, so to speak, on the utilization of Giapreza, the trade name. It's the only option you have for AT2. There isn't a ton of literature, of course. The study that I'm thinking of is, I think it was like a systematic review, like 200 or so patients were involved in it. And they were looking at the efficacy and safety of angiotensin 2 and cardiogenic shock. And in that study, they basically showed, suggested anyway, that not only was it safe, but you did actually have improvements in hemodynamic parameters and favorable outcomes when using AT2 in that population.
Yeah, I think the key point here is that there is a population of people with mixed shock, people who have both cardiogenic and vasodilatory, and that's where this drug is useful. I wouldn't use it in just cardiogenic. I would only use it if it was sort of both. At one sort of meta side note here, which first of all, you mentioned the Athos trial, and you were exactly right. I think it's amazing that the trials for this drug are Athos and Porthos. Unfortunately, there is an Aramis trial, but it's something completely different. So, they blew their chance at the Three Musketeers study section here.
Yes. I think the kind of bottom line on AT2 and cardiogenic shock is I'm sort of thinking about it or reaching for it. Well, A, if it's on my formulary, and it's not on a lot of formularies, or it's not on all formularies. But B, as sort of like a later on adjunct. Certainly, it's not taking the place of your inotropes that we classically use, things like norepinephrine, epinephrine, things like mechanical circulatory support. I mean, it's an adjunct that I think has been possibly shown to be safe and maybe helpful. But I'm not just like, oh, cardiogenic shock, let's put them on angiotensin 2.
But I will say that in my practice, in people who have this combined cardiogenic and vasodilatory shock, I often will reach for vasopressin and then AT2 in these folks, in addition to inotropes and other MCS interventions.
Totally.
So I think, the literature is small, a whopping 195 person systematic review, but I think it's growing, and I think there's a physiologic rationale that justifies it. And there's also enough evidence to demonstrate safety.
Awesome. All right, great. So we also got another comment actually on this episode from Thao Win about 4 months ago or so, who writes, "It's amazing to see how hard these authors work to benefit the rest. The episodes themselves are already a state of art. The notes provide a good background to better understand the episode, especially for those whose profession is not medicine like me, a pharmacist. Thank you for all the work and time that you put into educating us to be better clinicians. Thao."
Thanks a lot, Thao. Yeah, thanks for the shout out about the show notes. We do put a lot of time into that, and I'm glad that people are reading them and finding them useful. I'll just plug and say that for some of these episodes, we have like calculators where you can calculate like PAPI and cardiac power. We've got some interactive stuff. We've got some infographics. So there's a lot there. So thanks for doing the shout out for me.
Oh yeah, that's awesome. And thanks for being a pharmacist that listens to Critical Care Time. That's awesome too.
Yeah, you're definitely part of our target audience, by the way.
Yeah, good. Cool. Okay, so then one of, if not our most popular episode to date, Vasopressors, which in a couple parts there, but at least most popular topic gets a little love. So regarding one of our episodes on vasopressors, Sanjeev asks, "Have you ever seen a patient experience hypotension when giving phentolamine for catecholamine vasopressor extravasation?"
Short answer, no. Longer, better answer is, remember, you're not giving it systemically. The goal here is if somebody is getting peripheral vasopressors and they have an extravasation event, what you're doing is you're giving phentolamine into the area where the med has extravasated, in order to reverse the local vasoconstriction effects and avoid tissue damage. If you're doing it right, it shouldn't have any systemic effects. You're also giving a relatively low dose. You're giving enough to affect the local tissues, but even if you were to accidentally push some of it IV, it shouldn't affect their blood pressure much or at all. I would say go back and listen to, for people who haven't heard that episode, go back and listen to that episode because we detail exactly how to do this safely.
Absolutely. Yep. I have nothing more to add.
Laura Lindahl has a great question about hydroxycobalamin in sepsis, wondering about hydroxycobalamin use in sepsis. In recent studies on burns and inhalation injury cyanide poisoning, there are suggestions that hydroxycobalamin use has an association with increased risk of AKI. We concluded that in our small study as well. I would not be eager to use hydroxycobalamin in a patient group that has increased risk of AKI, as septic patients most certainly have. Otherwise, this is a great podcast, and I've really enjoyed listening to you both and your guests.
So yeah, theoretical and observational concerns. So hydroxycobalamin can discolor urine and plasma, and that in and of itself can interfere with some of the lab assays that we run. Things like, serum creatinine, your UAs, can also interfere with dialysis monitoring. And there are some case reports that suggest possible oxalate nephropathy, especially with high doses of hydroxycobalamin. Overall, though, there's really no definitive evidence of increased AKI risk in the controlled trials that we have available to us. One trial, so Gout et al. In the Journal of Cardiothoracic Vascular Anesthesia, and that was in 2020. So they looked at 321 cardiac surgery patients, and in that group, hydroxycobalamin was associated with a trend towards AKI, but it was not statistically significant after adjusting for confounders.
Yeah, the term trend towards is like a vasopressor for me. I hate that term because it's like not real, but I think it's real.
Yeah.
I think you're making a really good point here, Laura, and I share your concern. But I think it's important to remember that these are observational studies and these are sick patients. And this is a good example of what's probably confounding by indication. The people who are sick enough to need hydroxycobalamin are also more likely to get AKI independent of whether they receive the drug or not. I gotta say, I use this drug a lot in this population, and I haven't seen a clear association. Then again, you really need RCTs to find this out, and those haven't been done. I would say, if you want to play it safe, there is a lot more evidence for using methylene blue in septic shock. There's also a national shortage of hydroxycobalamin, so you can't use it right now. So you kind of have to use methylene blue. But I think the data so far is limited. But I think we will probably see more evidence of safety as we see more RCTs in the future.
Love it. Yep. Great points, Nick.
Okay, so in the Leading a Code episode, or in regards to the Leading a Code episode, Hassan Nadim on Twitter writes, "Last night I led a particularly atypical and traumatic code. It was my first such experience, and afterwards I helped organize a debrief modeled after what I'd learned from at Askins Razor at Nick M. Mark. Most important takeaways were, number one, moment of silence, giving staff the space to reflect on this traumatic experience and honor the life of the patient. Number two, what went well, center the positives. This can often get lost when a patient has recently lost their life, especially in an unexpected way. And three, what could we have done differently? It's okay to normalize that the code or care experience was not perfect. What can we do better next time?"
Yeah, I think that's awesome. I mean, that kind of feedback is like the best kind of feedback first and foremost. And it does kind of remind me, I know Nick, you and I are both big fans of The Pit, which, spoiler alert, hopefully it'll make an appearance in a future production. We'll see if we can kind of swing that. But
yeah, so we have some clips. We may get sued by HBO,
yeah,
or Max or whatever.
Yeah, I look forward to that. But in any event, yeah, that idea of taking a moment of silence, reflecting on the experience. I think it's so important. It's something that I think kind of can get lost in the sauce as we're moving from patient to patient and getting really busy. So yeah, it sounds like an amazing job in a tough situation.
Yeah. He put it more succinctly than we did. I think it took us an hour to say what he explained in 4 tweets. So yeah, nice job, Hassan. All right, moving on. There was a lot of discussion about the APP episode. starting with calling it the APP episode. Cyrus, I know you jumped into the fray a little bit on the message boards.
Oh yeah.
I don't know how much of this we want to read. There's some very long posts here, and what's that meme? Like, I ain't reading all that. I'm happy for you though, or sorry that happened.
Yeah.
That was kind of my first response. Though actually, on reading them more carefully, these are actually like some really good points and a really good discussion. I don't want to read everything, but maybe we can summarize some of the key points of this.
Yeah, I think so. I think like and key points of the topic in general. This is like an emotionally charged concept, or it's emotionally charged content for reasons that it probably doesn't, need to be. But I think there's this belief amongst many physicians that nurse practitioners and physician assistants, and what now we have like advanced practice respiratory therapists, or at least there's this concept of the advanced practice RT. All of these folks are out to quote unquote take our jobs as doctors. And so I think that whenever time is spent discussing the role of the NP or the PA in blank area of medicine, that can be triggering for some people. And I get it. I understand where that reaction comes from. But I think really our intention here with the episode was to try and highlight the collaborative role that exists, especially in the ICU, and also recognize the fact that, look, they're just, for better or worse, I guess I would say for worse, there aren't enough intensivists to go around. And so I think folks like Gary Macy, who came on, and other folks who've reached out to us, or that we work with in our personal professional lives, are really functionally force multipliers to help us fight this battle against critical illness. And so I think that's kind of my perspective on it. I think, we had a comment from Allen Ginsberg where he was sort of talking about the term APP, which there was definitely some confusion, the idea of us kind of not using it, and then we sort of used it in the show. I think that just speaks to the fact that like our tendency is to use a catch-all term, even though that catch-all term is not the best term.
Yeah.
So apologies for that, I guess. And then he kind of brought up the idea too of like the erosion of sort of preclinical or clinical requirements for folks going into nurse practitioner school or nurse practitioner training. That I will say that does kind of resonate with me. I do think that there's utility in having, for example, like critical care nursing experience prior to going to nurse practitioner school, just because of the nature of their schooling and the kind of focus of their schooling and the length and duration of their schooling as compared to medical training. I don't know. I don't want to keep rambling on, Nick. What are your thoughts on this?
No, I think you hit some of the key points. I thought it was actually a really nice discussion that they had back and forth. I'm just going to quote, I applaud Dr. Macy's, I refer to him as doctor in this setting, dedication to the field and respect his value and knowledge base. I also agree that there should be some type of certification program for NPs and PAs who want to work in critical care. Completely agree. I think I work with NPs and PAs almost every day in my practice.
Mm-hmm.
Couldn't do my job without them. I don't really view this as one of these like either or like coming for my job things. I think, having other people, doing your job with you maybe lets you as an MD operate more top of license, perhaps. I know that like in the anesthesia setting, having CRNAs generally means that the doctor anesthesiologists or MD anesthesiologists are maybe doing the more challenging, more complicated cases, and I think that's a good thing. I think in the critical care setting, this is an evolving field. The actual certification pathways are less clear than they probably ought to be and probably will be in a few years, but I think that's all really good. Regarding the sort of time and hour requirements, Tommy writes to us, hi there, my name is Tommy, I'm a PA. I wanted to let you know that I love listening to your episodes on critical care time as well as on Curbsiders, and I have learned so much over the last couple of years. I was listening to your most recent episode about the NP role in the ICU and really enjoyed listening to it. Only thing I wanted to mention is that Gary said PAs have 1,000 hours of patient care during their rotations. It's actually a minimum of 2,000. Anyway, thank you for the correction, Tommy. That's helpful.
Yes. I think there's one more comment, Nick, that you wanted to highlight.
Yeah, no, there's this one, AM-GC2WU, clearly some sort of evil droid, writes, Virtue signaling points earned. You can earn more hosting a barber next time. Like, okay. I don't think that's very productive. But
Yeah.
thanks for writing. We
Yeah.
appreciate all points of view.
Sure. Yeah. Maybe you do. I don't know. Okay. Yes. Thank you for writing. Disagree, but cool. All right. Let's move on.
Okay, moving on to the Hypoxemia Masterclass episode. Several people wrote to us about this one. Jacob Collin wrote to us. This is a phenomenal lecture. You covered many pearls of physiology, explained some tough concepts, used case-based examples for each topic you discuss, and it's quick and easy to understand. You guys have a real talent for distilling challenging subject matter into a quick and easy podcast. Well, I don't know if it was easy for us to make it, but I'm glad it was easy to listen to.
Yeah, and I know Jacob from the military, and he's like a very accomplished clinician. So really a physician scientist. So yeah, very high praise. I think I want to say he's also quite accomplished in the sleep realm. So pulm, crit, sleep, all that good stuff. So thanks Jake for your comments.
Here's a comment from somebody you may not know. It's from Anonymous. This episode was incredible. Maybe they mean the hacker Anonymous.
Yeah, I was going to say, maybe we do know this Anonymous.
Maybe we do know.
Bit worrisome.
Hey, it's for everybody who cares for the critically ill.
Sure.
This episode was incredibly insightful and tackled and covered a large amount of information efficiently. I appreciate the time and energy you all put into this. I'll be returning to this several times to be able to utilize this information in practice. Well, that's great to hear. Yeah. It's wonderful to hear that people are listening to an episode more than once even.
Oh yeah, this is much appreciated. And Nick and I really do put a lot of blood, sweat, and tears into these episodes, especially the ones that are physiology heavy, because we want to make sure that it's thoroughly baked, well done episode. And we're glad that you guys like listening to us talk about physiology and anatomy and all that good basic sciencey stuff.
I guess that means we got to do more episodes about physiology.
Okay, yeah, I'll just have to clone myself. Right.
Okay, moving on to the episode we did, the React episode when the groundbreaking Preoxy trial came out. Sean Bumbo writes about the Preoxy trial. So you conducted a study providing a respiratory rate on non-invasive ventilation. However, you did not ventilate the patient with an ambu bag. Presumably he means in the oxygen mask group. This seems like a very biased study. Cyrus, what do you say to that?
So I don't entirely agree. Interesting perspective. So the Preoxy trial did not explicitly forbid ventilation. And in fact, the study did allow for bag valve mask ventilation, or BVM, with or without ventilation, either the non-invasive ventilation or the oxygen mask group. The Preoxy trial did primarily focus on comparing preoxygenation with non-invasive versus preoxygenation with an oxygen mask. But again, it did not exclude the use of BVM during the intubation process.
Right. And there's a nice infographic that was published in the supplement of the trial that kind of shows what this looked like. To be fair to Sean's point, I went back and looked at this, and they actually used bag valve mask ventilation in 8.9% of people in the non-invasive group compared to 30% in the oxygen mask group. So while they could use an ambu bag to ventilate in arguing against this point, they didn't do it 2/3 of the time. And they did it a different fraction in each group. So I think those are valid criticisms of the study. I think I still think it's a robust study. I would have loved to see, and I went searching hard for this. I would love to have seen a subgroup analysis where they looked at people, in the oxygen mask group who got BVM ventilation during that apneic interval and compare them to the non-invasive group. They should have had enough power to do that. It's a shame. It's a shame that's not in there. Anyway, maybe next time we react, we can think of these things in time to suggest it to the author. But I think it's a technically untrue criticism of the trial.
Right.
But I think the spirit of the criticism is correct, and I wish the trial addressed the concern directly. So I think it's a really smart point.
I think that's a very good way of evaluating the criticism. I'm not sure that this was a very biased study, but I think the questions or the concerns that are brought up are totally valid.
It was only a 2/3 biased study, 1/3 unbiased.
Maybe when the post-Oxy trial comes up,
yes,
they can make those adjustments. Cool. Okay, so sticking with the theme of oxygenation and ventilation, We also got a comment again from Alan Ginsberg, who commented on the APP episode. This was on the extubation episode, saying, "Great episode. The only thing you didn't seem to mention is how long an SBT is supposed to last. I'm old enough to remember TP's trials, which were extremely labor intensive since you had to have people in the room for the entire trial, and 3-hour trials. I was also practicing when Martin Tobin's paper on the RSBI came out. It was far superior at the time to what we were doing, so NIFs, ABGs, spontaneous tidal volumes. And I totally agree with your approach, kind of a general gestalt approach, which factors into respiratory and non-respiratory factors. And I also like your ninja extubation or the crash extubation kind of terminology."
Yeah. Okay. Well, thanks, Alan. Friend of the pod, Alan. Appreciate all your comments. You make a couple of great points here. Yeah, we didn't talk enough about duration of SBTs in the episode, I guess. Several episodes suggest that longer studies aren't necessarily better, and somebody may tire out on a longer trial who would do fine with extubation. So in general, I would say 30 minutes is typically enough. In some cases, I'll extend it if I think they're really marginal and I want to see how they do for longer. But I think anybody who does a long enough SBT will get tired is
Yeah.
kind of one takeaway.
Yep.
I can only imagine what a pain it must have been to do like a 3-hour TP's trial. And since you can only be in one place at a time, like I just imagine that must have been like a real like resource limitation. Thinking about that episode, I think we were critical of the RSBI. But I think you make a good point that it was a big improvement over the standard of care previously. And I think this is an important thing to remember, right? That like sometimes with like the benefit of hindsight, it's easy to look at things and be like, well, that's not right. How could they ever have thought that was good? But even if something wasn't optimal, it might have still been a huge step function improvement over the standard of care at the time. Kind of like how early goal-directed therapy in sepsis, like we look back at that now and we're like, yeah, I don't know that a blood transfusion for an SVO2 of 70 or like bolusing for a CVP of 12, like I don't think those things make sense. But a lot of things that are in there, like early antibiotics, using fluids and pressors in a thoughtful way, like that's all become standard of care. So I think like it's important to remember that like RSBI may not be perfect, but it was still useful. It was a stepping stone to the modern approach. So
Yeah.
we don't need to
Yeah.
be too harsh on it.
No, I agree. I think only a couple things I would add is my review of the literature suggests 30 minutes is kind of like, in general, the shortest quote unquote amount of time. And 120 minutes is sort of about as long as you'd want the patient to go on an SBT. But obviously, there are caveats to that. And so I think one size fits all is not the right answer here. And then I also think, I love ranting on the RSBI, but the thing is, like, I didn't practice back when we were doing TP's trials. I've never done a TP's trial. I've never had to do a TP's trial. So actually, I really appreciate this comment because it brings a certain amount of perspective to me as a pretty young intensivist who didn't have the opportunity to grow up in that era when you didn't have anything, better to go off of. And I think to be, brutally honest with myself, after thinking about this and hearing this comment, I'm probably going to change my stance a little bit on the RSBI with that sort of historical perspective. So thank you, Alan.
All right. One episode that has gotten a lot of feedback, maybe even the most feedback of the entire season, was our episode Beneath the Drape, talking about the experience of doctors as patients. So Civic NG 9847 writes, amazing stories from two of the most extraordinary people. We are enriched not only from their medical experiences, but also from a human perspective. Another excellent episode with great interview from the hosts and guests.
And then this same person also writes that I listened to the episode the second time. It's even more amazing as to how graceful Dr. Gregosian and passionate Dr. Wishmeyer were. And thank you for saying this, how gracious the two of us were, Nick. Just amazing stories and experiences must listen to. So thank you for both comments.
Yeah, another fan of the pod, Tom from Johns Hopkins, wrote us to say, hey, Dr. Mark, Dr. Askin, my name is Tom. I'm currently a second-year PCCM fellow at Johns Hopkins. I've been listening to your podcast since it hit the market on Spotify, and I want to thank you both for the great content you put out. I've enjoyed all the episodes, but this season has been particularly good, and I've liked the focus on other topics within critical care. I love the latest episode, focusing on the other side of the drape. It's one of the best podcast episodes I've listened to in a while on any topic, and you should know that.
Oof.
Humanism in medicine has always been near my heart. And conversations like you had with Drs. Gregosian and Wishmeyer are so important to hear.
Wow. Thank you. That's very high praise to hear that. I think that feedback hits us hard in a very positive way. You know, one thing that we really set out to do is to create a big tent podcast. That doesn't just mean big tent in terms of the audience that we want to reach, but also the content that we want to include. And so it's important to us to underline the fact that critical care medicine is not just about the medicine itself, physiology, formulas. We love talking about that, don't get us wrong, but the person behind the patient is probably the most important thing to remember whenever you step foot in the ICU. So great to hear that listeners like it when we cover those topics. And I promise you that we have some more topics in that vein teed up for season.
Yeah, cosign.
Okay, so we've done some long form comments and a little bit of back and forth. Nick, are you ready for a rapid fire round?
Let's do it.
All right. So user, and I tried to figure out what this username meant, but user we7d3go5v, which also doesn't make sense in Leet speak either. So I don't know. It must be C3PO's burner account.
Yeah.
Something like that. Yeah. So I don't know who this is, but they commented, you don't want to infuse lactated ringers in cirrhosis. Other than that, fantastic. What do you think, Nick?
Yeah, so I think this is a common belief, but I think this is a false, a misconception or
black pearl.
That's so colorist, man. I've heard wooden pearl. I don't know. Whatever.
Wooden nickel. I don't know.
Maybe it's a wooden nickel. I don't know. Whatever it is, it's not the genuine article.
But why, Nick? But why? Won't their lactate just like go to 5 billion?
Yeah. So I think people were taught that cirrhotic livers can't metabolize lactate. So if you give lactated ringers, their lactate will get super high and they'll become super acidemic. There are a couple of mistakes here. So first, lactate isn't the same thing as lactic acid. Lactic acid is an acid. It lowers your pH, whereas lactate, or sodium lactate in this case, is a conjugate base. It doesn't cause acidosis. In fact, it can take a proton. Receive a proton.
Can mitigate the acidosis.
Exactly. That's why it's buffered. That's why it is balanced crystalloid. So, it is true that if you give somebody a liter of lactated ringers with 24 milliequivalents per liter of lactate in it, it will raise their lactate a little bit. So if you gave like a 85 kilogram person a liter of LR, you might expect their lactate to rise by like 0.5. And they're correct that the liver is responsible for about 70% of the metabolism of lactate. That said, though, even somebody with cirrhosis, their lactate can still metabolize just at a slower rate, and their kidneys can still metabolize and their muscle can still metabolize. So it's not like they can't metabolize this. It's just like the kinetics might be a little altered. Mm-hmm. So what that means is that if you give somebody with cirrhosis a liter of LR, their lactate will rise a little bit. It shouldn't worsen their pH. And then that rise in lactate, that 0.5 increase, might persist for, a little longer, say an hour or two instead of like 30 minutes. But I don't think that really matters. And I think it's also important to think about the flip side of this coin, which is that often these patients are getting lots of fluids. And we know from several studies that we'll talk about in a future episode that giving balanced crystalloids like lactated ringers may be better than normal saline in terms of renal outcomes. We know that the really high chloride load in NS and the really low pH of NS can be injurious to the kidney. And so I think that this is actually a population where I am more likely to reach for LR because I think they're likely to get several liters of it. And, they're less likely to get renal injury from the high chloride content of NS.
Yeah, totally agree. Cosign all of that. The only thing I'll do maybe is put in a plug for an episode we have planned on lactate. So demystifying lactate. That's one that we're really excited to bring to you guys, hopefully early in season 3. So for people that like those physiology heavy episodes, I think this one's going to be quite the haymaker.
Oh yeah. Get excited.
Yeah.
All right. Lightning round. We're going fast, right?
Yes.
So regarding pleural infections, Sekurfi writes, antibiotic selection is an important point that was not discussed in detail. The data would suggest that anaerobic co-infections are high, perhaps 20%, but difficult to culture, high enough that one should strongly consider coverage of these organisms, even if culture is positive for a non-anaerobic single organism. I'm having a little trouble parsing non-anaerobic. Is that aerobic? Yes. I don't know. double negative.
Yeah. Either way, great point. And we definitely should cover that. Maybe we can do that in one of our ID focused episodes that we have planned for the future.
Yeah, and I'll just say that I saw this exact point illustrated recently.
Nice.
That, just because you culture one organism in pleural fluid does not mean there isn't another organism that will grow out more slowly. And so I think, it's a great reminder that even though it's good practice to wean antibiotics and narrow antibiotics, sometimes you don't want to do it the first possible second. You want to consider like what is the pretest likelihood that this is a polymicrobial infection, and what is the likelihood that there may be something slower growing in here as well.
Mm-hmm.
So I really smart point. Obviously, antibiotics need more discussion in this podcast in general. Looking forward to more of that content coming soon. Okay, K Mode 7936 writes, "Keep doing what you are doing. Watching you all the way from Bulgaria."
Thanks for your comment, K-Mode, and glad you're listening to us from, way far away. That's awesome. Cool. Okay, another listener writes, "Guys, I like your choice for topics and host. Thank you. And of note, this was written in Arabic, so very cool."
We like our choice of hosts too, as it turns out.
Yes. We have no choice in the matter, unfortunately, but here you are. Here we are. Sorry.
Hey, we hang out outside of the podcast.
That's true.
Yeah, we could have done a lot worse.
That's true.
All right. Brooklyn 99 Faith, awesome name, writes, thank you for always great content. I am an ICU nurse and have learned so much thanks to you guys. Amazing work. Thanks. Aw, appreciate that.
Yes, thank you. Another comment we have from Micah Sims 6455. Best medical podcast. Woof, thank you.
Damn, that's good.
Yeah.
Regarding the cardiac arrest episode, LIT Nursing, maybe that's Lit Nursing,
maybe.
Writes, loved this, was so wholesome. Well, that's nice.
Oh, yes. I like to think of myself as wholesome. Awesome. And then regarding our ARDS episode, this was John W8403. Extremely interesting and informative podcast. Been craving Crit Care podcasts since IBCC stopped putting them out. Perfect level of detail for a medicine resident interested in pulm/critical care medicine. Thanks. We appreciate it.
Yeah, we'll keep them coming. David, regarding the thrombocytopenia episode, writes, excellent review as we deal with this quite frequently in the MICU. Succinct, informative. Thank you, all caps. No, thank you, David.
No, thank you. And thank you, Matt Rendo, for being our awesome guest for that episode. All right, so we'll keep it rolling. So Stacy Fisher via Apple Podcasts says, I'm an early career intensivist, and I find the show incredibly helpful for diving into the nitty-gritty practical details that are highly relevant to my everyday practice. You all are brilliant. Oh, thanks. I'm a huge fan and wish you could release an episode every day. Oh my gosh.
That sounds like a lot of work, man.
Yeah, I would probably die.
Isella Mack, also via Apple Podcasts, writes, I'm an ICU nurse with 13 years of experience in the largest and sickest county hospital in DFW. I really appreciate this podcast. You have interesting and relevant critical care topics. They're an awesome review for myself and our new critical care nurse residents. The podcast helps me to teach precept better. Please continue this podcast. Would appreciate if you could cover in-depth review of each kind of shock, ARDS, ventilator modes, hemodynamic monitoring parameters, ECMO. So of the list that she gave us in season 2, we talked about cardiogenic shock. So we hit one type of shock. We talked about ARDS, and we talked about ECMO. So we got about half
shock.
of septic shock. That's right. So we hit about half of that wish list and agree. I mean, ventilator modes, hemodynamic monitoring, those are definitely on our to-do list. So thank you for that.
Another comment via Apple Podcasts. This comes from XXABWUENSJ. Don't know how you're supposed to pronounce that.
Is that your password, dude?
Yeah. Oh, dang it. No. $$ at excellent. Yeah. And then I'll follow it up with my social security number. Loving this podcast. Great content and well presented. Cyrus and Nick break down concepts nicely, and I love their frequent summaries. Use of expert guests for certain topics has also been great. In my humble opinion, best critical care podcast around today. Thank you, person whose name I cannot pronounce.
Keteronium Always, great name, writes, as a third-year staff intensivist, I feel like this podcast was tailored to my needs. However, it is clearly beneficial to all the health members that work in the ICU. I appreciate the evidence-based medicine, excellent fundamental and esoteric knowledge, along with practice preferences of Nick and Cyrus. I have highly recommended to my colleagues who also love the podcast. Excellent work, Nick and Cyrus.
Oh, that is awesome. Yeah. Probably the one thing we prefer above feedback to us is y'all spreading the gospel, so to speak, amongst your colleagues, whether they're, physicians, nurses, pharmacists, who, by the way, Nick, we really need to get pharmacy on and, physical therapy and some of these other folks that we really want to incorporate in the pod. But yeah, we very much appreciative of that. Maybe because I'm like a third, fourth year staff intensivist. That may be why the approach resonates with you. I don't know. But thank you. Thank you for your comment.
Yeah. And great name. Peteronium. Awesome name.
Awesome. And then we have another comment from @GabrielJones4866. Are these guys all jazzed up on Colombian dark roast? ?
So people who are watching us on YouTube can see that we are in fact drinking coffee as we record through one of our critical care mugs. Go to the website to buy that. I do want to address a really important misconception that dark roast coffee contains more caffeine. This is not true. Per a very, very heated discussion I found on Reddit, light roast beans actually are a little bit denser. And so if you measure coffee by volume, you actually get more caffeine with light roast. But yeah, we love caffeine over here at Critical Care Time.
We sure do. And, it's, man, I don't know what I'd do without coffee. So, it would be a sad day.
All right. KLI Christina via Apple Podcast writes, you guys are the best, absolutely the best. Thank you for sharing your knowledges and experiences. Thank you so much.
Thank you. We've also got @GabrielWoll 5918. You guys are the best. As an ICU nurse seeking career advancement as a CRNA, I really glean a ton from your contributions. You've got a follower for life. Thanks, guys. So that's an awesome comment. And then we've got another one here. This one is specific for Nick, Bonecutter01 via Apple Podcast. Dr. Mark is a highly intelligent provider and has a passion for critical thinking and sharing his knowledge with others. Also, check out his one-pager notes. That co-host is kind of an idiot.
Yeah. I know who this is. Thanks a lot, Robbie. And I know you're kicking ass and taking names in CRNA school. So yeah, we
Nice.
miss you in the CVICU.
Aw.
But Cyrus, don't feel left out, man. You got some shout outs too, bro. Tube MR Happy writes, Cyrus has some all caps insane guns.
Oh,
3
wow.
exclamation points.
That's really embarrassing. That must come from the episode that we recorded together. And I think I made a point of wearing a shirt with sleeves that were like several sizes too small just to really accentuate my arms.
Were you even wearing a shirt? Yeah.
I don't know. Like things got pretty hot and heavy in there. I don't even remember. But yeah, no, I appreciate it. That's very kind of you. I do try to, Nick causes me a lot of frustration in my day to day. So I have to spend a lot of time in the gym kind of working that out. So.
All right. Regarding the PE episode, Vinca Alkaloids 6732.
Nice.
Awesome name. That's a great name.
Yeah.
Truly an enlightening discussion. As a critical care medicine resident, your channel is a massive help. Absolute Jag 9 also writes, excellent presentation. PE is so high yield. Yeah,
For
we
sure.
love talking PE. We'll have to do more.
Yes. Yeah. Hopefully we'll be able to. Okay, so one of our longtime fans, Anthony Rayner @AW Rayner on X, says, speaking with the Impella rep who did ECMO in the past, showed him the podcast I was listening to. He said @Crit Care Time, @Nick M. Mark, and @Askins Razor were quote unquote big deals.
Thanks so much, man. That's nice to hear it. And hey, Biomed or J&J, if you're listening, we would love to have you as a sponsor if you think that.
Yeah, let's do it. I love it. Yeah, give us a shout. Cyrus @criticalcaretime.com or Nick @criticalcaretime.com. Okay, cool. Another comment we have from @Abdul Hakim Al Marzouk. I think is what it is. Abdul Hakim Al Marzouk 9083. Thank you. It's the Arab heritage. It's making an appearance here. Great talks. I just started my critical care residency and I feel lost by the amounts of books I read. Would you please recommend some books that could give me a great base of knowledge? Thank you.
I've actually been thinking we should do an episode about our favorite learning resources, textbooks, books, podcasts, other things. That might be a fun one to put together. Yeah. Thanks for the suggestion. Appreciate it. Adam Jackson from Down Under writes, hey team, love your podcast. It's become a very useful tool for me to quote study while not studying. I'm getting used to swapping your Americanisms / language for our much more uncouth and cursive Australianisms. E.g., we don't commonly use shock as a diagnostic label. Rather, we tend to say, shit's all mate. LOL, kidding.
Yeah, I'm sure that Adam will really appreciate your horrible Australian accent. You just
I didn't really try very hard there.
No,
It's true.
No, it's okay.
That was an uncouth Americanism, I think.
That's true. Yeah. Well, Adam, we enjoyed your listening to our podcast and your previous, fandom, and we apologize for
and I just want to reassure you that we are very uncouth when we're not on this family friendly podcast.
Yes, we're very uncouth. Our couthness is set to 0, but our lactate's set to 11. Okay, so Jesse Kelso on Instagram writes, "Hey guys, I'm a first-year fellow up in Chicago. I was curious as to your thoughts on the idea of an episode on landing the sick ICU patient." Very cool. So basically, the outside hospital transfers a patient, they arrive, or you're getting a patient from the ER. What do you all typically do to allow nursing time to set up? What, how do you just approach that patient in general, get things cooking in the right way? Says he's a big fan of the podcast. All the best if you guys are already too busy. Awesome episode.
I think that's another fantastic suggestion.
Totally.
I'm already thinking kind of how you would do that. There's sort of like the anticipating and preparing step, like what drips do you have? What kits do you have? What equipment do you have in the room? How do you sort of brief the team and prepare? And then what do you do in the first minute, the first 5 minutes, the first 30 minutes? Like there's some meat on those bones. There's a great episode there. We got to do that. Thank you, Jesse. That's a great suggestion. All right. Marissa Aaron writes, got the hat. Thank you. Oh, this is somebody who ordered from our store.
Yes.
Love the podcast, but as a neurointensivist, I'm feeling a bit neglected. When are you guys going to get into some NCC topics?
Well. This has been on our agenda for a while. We have several topics lined up for season 3 and some guests we're pretty excited about. So yeah, keep listening and you'll find out. But I think sometime in the next few months or so, we should be breaking into that territory.
Thanks for putting up with us for 50 episodes before we got to what you were interested in.
Yes.
Mad City Bells writes, I thank the gods of critical care for you guys. Really looking forward to the episode on ECMO.
Oh, good.
Well, we had an episode on ECMO, so I'm glad we listened to you. I also want to know more about the polytheistic pantheon of critical care gods. We should probably talk about that in the future.
Yeah, probably should. That would be a nice little bonus episode. Who would those gods be? I wonder.
Loki.
Yes. Okay, cool. So another comment we have from Cal Nurse Sarah. Hi guys, I'm an ICU nurse and I've been listening to your show from the beginning. I meant to reach out to you earlier to let you know how awesome your show is and how much I appreciate it, but I really felt compelled after your last episode on obstetric emergencies. Yeah, that one was a big episode. So grateful for Dr. Mora and for Dr. Levine coming on and chatting with us about that. Huge topic. Glad we tackled it.
Yeah, I feel like I learn from doing all of these episodes, but I feel like I learned a lot from that one. So that was really great.
Agreed.
Lindsay Cunliffe writes, hi, I just wanted to say thank you for all of your excellent episodes. I started a new job as an NP in the CTICU in Seattle recently, and I can't believe how lucky I was to find a podcast that seems tailor-made for my job. I tell everyone I work with about it, especially new hires. It's been a daunting transition for me after years in acute care, so any help along the way has been much appreciated. Well, thanks, Lindsay. I know that ICU well. That's part of where I trained. So yeah, glad to see that our podcast is making you feel comfortable there.
And finally, we have Lavigotah, Lavigotah, maybe it's Lavigotah, 4706, simply says, favorite podcast, celebratory emoji.
Perfect note to end on. Thank you so much. All right. Well, it was great to hear all that feedback, man. That was really fun. What do you say, Cyrus? Should we do another season?
Well, I guess the cat's out of the bag because we sort of already alluded to season 3 about 25,000 times. But to answer your question, Nick, twist my arm, why don't you?
Yeah, I think we're in this for a few more episodes. Anyway, big thanks to all of our listeners. We appreciate all of you. We love the feedback you've shared. Please keep it coming. As always, we really appreciate it if you subscribe, leave us a 5-star review. Go to the website, check out the show notes, as you heard listeners commented on. That's a lot there. We put a lot of time into it. Hopefully it reinforces what we talk about in the show with graphics and visuals and interactives and all that. And while you're there, you should definitely sign up for our newsletter. It's free. It's got great content in it. We got a member of the team who's working on it, and she's fantastic.
Mm-hmm.
Yeah. You should also go to our store and see if there's something there, like, these awesome cups I'm drinking out of.
Or this, yeah. Soon this shirt, hopefully.
Or the shirt that he's wearing. Yeah.
Hopefully we'll get that up there soon.
Also, be sure to hit us up on social media. The show is at Crit Care Time, at Critical Care Time, at Crit_Care Time, or some other permutation across different platforms. You can also hit us up individually at Nick M. Mark, at Askins_Razor.
And of course, like we always do, and I think it's fitting at the end of this here season 2, we want to thank our sponsor, C-Star Medical. We're fortunate and grateful that this episode and all episodes in season 2 of Critical Care Time have been sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, www.cstarmedical.com, to learn more.
As always, big thanks to our team at Podpaste for making this show a reality. Thanks to Kurt Belknap for our awesome theme music, which you're hearing now.
That's right. And then just a brief disclaimer for this episode is really just the views that we expressed here within this podcast, and any associated media do not necessarily reflect the views of our employers. With that, thank you guys so much for listening to this, to season 2, to season 1. Thank you for being the kind of wind beneath our wings. And
wow.
And, yes, I know. It's really, I'm just
Can we edit that out? Actually, do not edit that out. I want that to live forever.
Thank you, in perpetuity. I'm just feeling really touched right now. I'm just right in the right.
Aw.
I am Dr. Cyrus Askin. Thank you guys so much, and so long.
And this callous jerk over here is Dr. Nick Mark. See you next time.